systemic effects of inflammation, and then tissue repair. But for this afternoon, I will only discuss the first two, the overview and the acute inflammation. So for the overview, although the clinical features of inflammation was described in although it was described in the Egyptian papyrus dated around the 300 BC, a Roman writer in the first century, who is Celsus, first listed the four cardinal signs of inflammation, which includes the rubor or the redness, tumor, swelling, calor, heat, and then the dolor or the pain. In 19th century, Rudolf Virchow uh, added the fifth clinical sign of inflammation, which is the loss of function or the function lysa. In 1793, John Hunter, who is a surgeon, uh, says that inflammation is actually not a disease but a response that has a salutary effect on the host. And then in 1880s, the Russian biologist who is Eli Michnikov discovered the process by phagocytosis, observing the ingestion of rose thorns by the amoebocytes of starfish larvae. And then he concluded that the purpose of inflammation was to bring the phagocytic cells to the injured area by to engulf the invading bacteria. And then Sir Thomas Lewis, he studied the inflammatory response in skin, and then he established that the concept that the chemical substances such as the histamine, they mediate the vascular changes of inflammation. And this fundamental concept underlies the important discoveries of the chemical mediators of inflammation and the use of anti-inflammatory drugs in clinical medicine. So inflammation is a response of vascularized tissues that delivers the leukocytes and molecules of host defense from the circulation to the sites of infection to eliminate the offending agents. It treats the host of both the initial cause of injury like the microbes and the toxins, and then the consequences of this infection like the necrotic cells and the tissues. And the mediators of defense includes the phagocytic leukocytes, the antibodies, and the complement proteins. Without inflammation, infection would go unchecked and the wounds would never heal. And then they added the suffix itis, which denotes the inflammation. For example, in the appendix, inflammation of the appendix is known as appendicitis. Likewise, the infection of the conjunctiva and the meninges is known as the conjunctivitis and then the meningitis. So the components of the inflammatory response, the major participants in the inflammatory reactions in tissues are the blood vessels and the leukocytes. The blood vessels, they respond to inflammatory stimuli by dilating and by the increasing their permeability, allowing the circulatory proteins to enter the site of infection or the tissue damage. And then the endothelium lining the blood vessels, they also change such that the circulating leukocytes, they adhere and then they migrate into the tissues. And then the leukocytes, once recruited, they are activated and acquire the ability to ingest ingest and then destroy the microbes and the dead cells, as well as the foreign bodies and other unwanted materials in the tissues. Hello? Now, wara ako.
Yes po, Doc. Pero
Di na
nandito ka na.
ako nautod. Nautod, warayla. Di na ako nag-stop.
Parang nag-freeze ka po ha. Third slide mo na po ba yun or second slide po? Diyan po ata, Doc.
Hindi nautod.
Slide 5 ata po, Doc. According to our classmate po, Doc, slide 6, Doc.
Okay, so as I have said, wait lang ha, sorry. Nababatian ako niyo. Okay na.
Yes po, Doc.
Wait lang ha. Okay na. So the major participants in the inflammatory reaction includes the blood vessels and the leukocytes. And then the blood vessel, they respond to inflammatory stimuli by dilating and by increasing the permeability, allowing the circulating proteins to enter the site of infection or the tissue damage. And then the endothelium lining the blood vessel, they also change in response to inflammation, such that the leukocytes, they adhere and then migrate into the tissues. And once the recruited leukocytes, they are activated and are able to ingest and destroy the microbes, the foreign body, and other unwanted materials in the tissues. However, the protective inflammatory response reaction to infection, they are often accompanied by the local tissue damage, and it is associated with signs and symptoms like pain and functional impairment. Typically, these harmful consequences, they are self-limited and then resolve as the inflammation abates, leaving little or no permanent damage. So in contrast, there are many diseases in which the inflammatory reaction is misdirected. Example, they are the inflammatory response against the cell tissues in autoimmune diseases. They are also occur against the normally harmless environmental substances like in allergies or is inadequately controlled. So the examples of harmful consequences of inflammation includes the rheumatoid arthritis, the atherosclerosis, lung fibrosis, and hypersensitivity reactions. So in these cases, the normally protective inflammatory reaction, they become the cause of the disease, and damage it causes is the dominant picture. And sometimes they are referred to as the silent killer. So these are the list of the diseases caused by inflammatory reactions for acute inflammation. Examples are the ARSD, asthma, the glomerulonephritis, and then the septic shock. So for the local and systemic inflammation, these are the inflammatory response to a localized infection or tissue damage. For example of this is the fever. So although the local reaction, they have systemic manifestation, the inflammation is still confined to the site of infection or damage. In rare situations, such as disseminated bacterial infection, the inflammatory reaction is systemic and it can cause widespread pathologic abnormality. And this reaction is called sepsis, which is a form of systemic inflammatory response syndrome. So the steps in inflammation includes recognition, wherein the cells involved in inflammation, like the sentinel cells and the phagocytes, they are equipped with receptors that recognize the microbial products and substances released from the damaged cells. And then the engagement of the receptors, it leads to the production of the mediators of inflammation, which will be discussed later. And these trigger the subsequent steps in inflammatory response, which includes which is next step is recruitment. The recruitment of the leukocytes and the plasma proteins into the tissues. So when a pathogenic microbes, they invade the tissues or the tissue cells die, the leukocyte first, mainly the neutrophils, and then the monocytes, and then the lymphocytes, and then the plasma proteins, they are rapidly recruited from the circulation to the extravascular site when the offending agent is where the offending agent is located. So usually, inihira nga mga monocyte, mga lymphocytes, at ha blood vessels. So kung may ada inflammation, na-dilate ang atong blood vessels, and then iya mga endothelial cells na loosen hiya, kaya ang mga inihiya nga mga inflammatory cells, mga WBC, nagawa siya nga duhang blood vessels, ikatuhan tissues nga damage o may an infection. So, and then the removal of the stimulus for inflammation. This is accomplished by the phagocytic cells, which ingest and then destroy the microbes and the dead cells. And then regulation, this is important for terminating the reaction when the purpose is accomplished. And then the last is repair, which consists of series of events that heal the damaged tissues. And this process, the injured tissue is replaced by through generation, surviving cells, and filling of the residual defects with connective tissues or scarring. So this picture shows the sequence of events in inflammation. So the first is recognition. So the cells, they recognize in the microbes and the toxins, and then also the damaged cells, and they liberate the mediators like the cytokines and the growth factors that triggers the vascular and the cellular reaction of the inflammation like the vascular response, the blood vessel dilatations. And then the mediators of inflammation, they are triggered by the soluble factors that are produced by the various cells derived from the plasma proteins and are generated or activated in response to the inflammatory stimulus. So the microbes, the necrotic cells, and hypoxia, they can trigger the elaboration of the inflammatory mediators and elicit inflammation. And such mediator, they initiate and amplify the inflammatory response and determine its pattern, the severity of infection, and the clinical and pathologic manifestation. So acute and chronic inflammation, there is a distinction between the two. This was originally based on the duration of the reaction. For acute inflammation, usually it is rapid, self-limited, and the offending agents, they are readily eliminated, such as the bacteria, the fungi, and the dead cells. It also develops within minutes or hours and is of short duration, usually hours to few days, and is characterized by the exudation of fluid and plasma proteins and the immigration of the leukocytes, predominantly neutrophils. While chronic inflammation, they may follow the acute inflammation or may arise de novo. So the causes of inflammation includes infections, tissue necrosis, the presence of foreign bodies, and the immune reactions. So for infection, the microbial toxins, they are among the most common and the medically important causes. And the outcomes are determined by the type of pathogen and the host response. So in tissue necrosis, regardless of the uh, tissue necrosis, they elicit inflammation regardless of the cause of cell death, and the cells die because of ischemia or the reduced blood flow, which is usually the cause of myocardial infarction. Also trauma, and then physical and chemical injury like the thermal injury and in burns or frostbites. Presence of foreign bodies like dirt, sutures, they may elicit inflammation because they cause traumatic tissue injury or carry microbes. And then the immune reactions, also called hypersensitivity reactions, they are reactions in which the normally protective immune system, they damage the individual's own tissues. So the recognition of microbes and damaged cells, they are the components or substances are released from damaged cells. This is the initiating step in the inflammatory reactions. So the cellular receptors for microbes, the cells express receptors in the plasma membrane, and then the endosomes and the cytosol uh, enable the cells to sense the presence of the foreign invaders in any cellular compartment. And the best defined these receptors belong to the toll-like receptors or the TLRs. And then sensors of cell damage, they have the NOD-like receptors. And these molecules, they include the uric acid, the adenosine triphosphate, and even the DNA, which is released into the cytoplasm and not sequestered in nuclei as it should be normally, and many others. These receptors, they activate the multi-protein cytosolic complex called the inflammasome. So other cellular receptors involved in inflammation. These receptors, they recognize the microbes coated with antibodies and complement, and they promote ingestion and destruction of the microbes as well as inflammation. And then the circulating proteins, the complement system, they react against the microbes and they produces mediators of inflammation. The circulating protein called the mannose binding lectin, they recognize the microbial sugars and they promote ingestion of the microbes and the activation of the complement system. So the typical inflammatory reaction, they develop through a series of sequential steps, which includes the recognition, recruitment, the removal of stimulus, and then regulation of response, and then repair. So for acute inflammation, there are three major components. One is the dilatation of the small vessels, and then second is increased permeability of the microvasculature, enabling the plasma proteins and the leukocyte to leave the circulation, and third is the immigration of the leukocytes from the microcirculation. So when an individual encounter an injurious agent like the microbes or the dead cells, phagocytes that reside in the tissues, they try to eliminate these agents. And then at the same time, these phagocytes under the sentinel cells in the tissues, they recognize the presence of the foreign or the abnormal substance and react with the liberating cytokines, the lipid messengers, and then other mediators of inflammation. So some of these mediators, they act on the small blood vessels and promote the efflux of the plasma and the recruitment of the circulating leukocytes to the site where the offending agent is located. So for the reactions of the blood vessels in acute inflammation, this includes changes in the vascular flow and caliber. As the changes in the vascular flow, they begin early after the injury and consist of vasodilation, uh, So this is induced by the action of several mediators, and the most notable is the presence of production of histamine on the vascular smooth muscle. It is one of the earliest manifestation of acute inflammation, and vasodilation first involved the arterioles and then the opening of the new capillary beds. And then this result in increased blood flow and causes the heat and the redness, also known as erythema. So vasodilation is quickly followed by increased permeability of the microvasculature with the outpouring of protein-rich fluid into the extravascular tissues, and process is described later. So the loss of fluid and increased vessel diameter, they lead to slower blood flow, a concentration of the red cells in the uh, small vessels, and increased viscosity of the blood, so nagiging malapot ang dugo. And these changes, they result in the engorgement of the small blood vessels with slowly moving red cells, and this is a condition termed as stasis. And this is seen as vascular congestion and localized redness of the involved tissue. At siya nga mapula kung may the inflammation, napula ang tissues and area involved. So as these stasis develop, the blood leukocytes, principally the neutrophils, they accumulate along the vascular endothelium, and at the same time, the endothelial cells, they are activated by the mediators and the tissue damage at the site of infection and tissue damage, and they increase the levels of adhesion molecules. And then the leukocytes, they then adhere to the endothelium, and then soon they migrate to the vascular wall into the interstitial tissue in a sequence that is also described later. So for the changes in the vascular flow of caliber, this the so increased vascular permeability or the vascular leakage. This is the hallmark of acute inflammation. So the contraction of the endothelial cells result in opening of the interendothelial gaps, and is the most common mechanism of vascular leakage. So this is elicited by histamine, the bradykinin, the leukotrienes, and other chemical mediators. And then the endothelial injury, this result in the endothelial cell necrosis and detachment. So this also The neutrophils also injure the endothelial cells, and then the leakage start immediately, causing a life-threatening loss and a fluid in severely burned patients. So this is a picture of the principal mechanism of increased vascular permeability in inflammation and their features and underlying causes. So normally, the leukocytes are located inside the lumen of the blood vessels, also the plasma protein. So these are the lining of the blood vessels, which are the endothelial cells. So when there is inflammation, the blood vessels, they dilate, and then the endothelium may nahihiya space so that the WBCs, usually the neutrophils and the lymphocytes, they go out of the blood vessels and into the tissues. So, ang endothelium na gugubahiyan, may daniya yung mga space, which is dapat waray hiya dito ang mga space. So, ang tendency, may danahiya imbalance asya na may, kung may adaptation nga may adaborn, may nagkakaadahin severe dehydration kasi may danali din mga buho hanging blood vessel. So, nagawas ang fluid gihapon. So, responses of the lymphatic vessels and lymph nodes, in addition to the blood vessels, the lymphatic vessels, they also participate in acute inflammation. So, the system of the lymphatics, they filter the extravascular fluids, and they drain the small amount of the extravascular fluid that seeps out of the capillaries in the healthy state. In inflammation, the lymph flow is increased and helps drain edema fluid that accumulates because of increased vascular permeability. So in addition to fluid, the leukocytes and the cell debris, as well as the microbes, they also go to the lymph. And then the lymphatic vessels, like the blood vessels, they also proliferate during inflammation to handle the increased load. So they become secondarily inflamed, known as the lymphangitis, as may the draining lymph nodes. Kung may the infection and immune lymph nodes, known here as lymphadenitis. So the inflamed lymph nodes, they are often enlarged because of the hyperplasia of the lymphoid follicles and the increased numbers of the lymphocytes and the macrophages. So this picture shows how the exudates and the transudates are formed. So the exudate, so normally, as I have said before, just a while ago, ang imo endothelial cells, waray hiya dapat gap in between. So ang imo plasma proteins, adilay sugad pati ang imo mga cells. So kung may ada na gap, may ada na didi gap, so the exudate, ang imo fluid diha sulod, nagawa siya nga diha surrounding tissues, and also the protein molecules na nagawa siya. So ang imo exudate, it is an extravascular fluid high in protein concentration and contains cellular debris. While ang imo transudate, these are fluid with low protein content kasi dili nakakagawa sa imo proteins kitang dili sulod sa imo blood vessels. So ang nagawas lang ang fluid lang. So examination ng iya result, few lang iya cells, low gihapon ang iya protein content. So exudate, usually the exudate is caused by increased enteroendothelial cells and then vasodilation and stasis. While in transudate, there is an increase in the hydrostatic pressure lang na increase. So for the reactions of blood vessels in acute inflammation, So these vascular reactions, they consist of changes in the flow of blood and the permeability of the vessels. So acianato and presence of exudate and formation of transudates. And then also the edema, presence of edema due to excess fluid in the interstitial tissues or the serous cavities. And then the formation of pus or a purulent oxidate. So this is an inflammatory exudate rich in leukocytes, mostly neutrophils. And then the debris of dead cells, and in many cases, microbes are also present in purulent oxidate. So leukocytic recruitment, so the changes in the blood flow and the vascular permeability, they are followed by the influx of leukocyte into the tissues. So nagawas na ang mga leukocyte ng tuha blood vessel tikat tuha infected nga area. So they perform the key functions of eliminating the offending agents. And the most important leukocytes in typical inflammatory reactions are the ones capable of phagocytosis, namely the neutrophils and the macrophages. So they ingest and destroy the bacteria and other microbes, as well as the necrotic tissue and the foreign substances. And macrophages, they also produce the growth factors that aid in repair. So the journey of leukocytes from the vessel lumen to the tissue, it is a multi-step process that is mediated and controlled by adhesion molecules and cytokines called the chemokines. And this process can be divided into sequential phases. And so in the lumen, there is the leukocytes, they undergo margination and then rolling and then adhesion to the endothelium. And then the vascular endothelium, they do not bind the circulating cells or allow the passage of the cells. But in inflammation, the endothelium is activated and they can bind the leukocyte as a prelude to the exit from the blood vessels. And then they migrate across the endothelium and the vessel wall, and then they go to the tissues toward a chemotactic stimulus. So in normally flowing blood in venules, the red cells, they are usually confined to a central axial column displacing the leukocytes. And but because of the dilatation of the inflamed post-capillary venules, the blood flow and more white cells, they assume a peripheral position along the endothelium surface. So So the margination, the white cells, they assume a peripheral position along the endothelial surface, and then in rolling, they send signals from the endothelium, recognizing the adhesion molecules on the endothelium, and then adhesion to the endothelium, which is enhanced by the cytokines secreted by the sentinel cells in the tissues, and then the selectins are produced, and then the integrins, they bind more firmly to the endothelium. So in transmigration or diaphadesis, this is the migration of leukocytes through the intact endothelium. It occurs mainly in the post-capillary venules, and usually the CD31 or the PCAM1 are the plated endothelial cells adhesion molecules. And after the transversing the endothelium, the leukocyte, they pierce the basement membrane, secreting the collagenases, and then they enter the extravascular space. So chemotaxis of leukocytes, after exiting the circulation, the leukocyte, they move into tissues toward the site of injury by a process called the chemotaxis. So this is the most common exogenous factors. There are bacterial products, including the peptides with N4-meal thionine terminal amino acids and some lipids. And then the endogenous chemoreactants, they include several chemical mediators like the cytokines, the components of the complement system, and the arachidonic acid metabolites, specifically the leukotriene B4. So all these chemotactic agents, they bind to specific 7-transmembrane G protein coupled receptors on the surface of the leukocytes. So the net result is that the leukocyte, they migrate in the direction of a locally produced chemoattractants emanating from the site of inflammatory stimulus. So the nature of the leukocyte, they infiltrate, vary with the age of the inflammatory response and the type of stimulus. Usually, uh, in the first 6 to 24 hours of inflammation, the neutrophils predominate, and then they are replaced by the monocytes in 24 to 48 hours. So in certain infections, for example, in Pseudomonas bacteria, the cellular infiltrate is dominated by continuously recruiting neutrophils for several days. In viral infection, the lymphocytes predominate. They are the ones to, they are the first cells to arrive. And then in helmintic infection and allergic reactions, the eosinophils are the main cell types. So the two major phagocytes are the neutrophils and the macrophages. So all these cell types, they share many functional properties, but they also differ in significant ways. So the recognition of the microbes or the dead cells, they induce several responses in the leukocytes and are collectively called the leukocyte activation. And this activation, they result from the signaling pathways that are triggered by the leukocytes, resulting in increase in cytosolic calcium and activation of the enzymes such as the protein kinase C and the phospholipase E2. And the destruction of the microbes and other offenders are phagocytosis and intracellular killing. So several other responses, they aid in the defensive function of inflammation and may contribute to injurious consequences. So phagocytosis involves sequential steps like recognition and attachment of the particle to be ingested by the leukocyte, engulfment with subsequent formation of phagocytic vacuole, and killing of the microbe and degradation of the ingested material. So the phagocytic receptors involved are the Manus receptors, the scavenger receptors, and receptors for various opsonins, which enable phagocytes to bind and ingest the microbe. So the macrophage Manus receptor is a lectin that binds the terminal mannose and the fucose residues of the glycoprotein and the glycolipids in the surface of the microbes. And these sugars, they are typically part of the molecules in the microbial wall. So therefore, the mannose receptor, they recognize the microbes and not the host cells. So in engulfment, After the particle is bound to phagocyte receptor, extension of the cytoplasm, they flow around the microbe and then the plasma membrane, they pinches off to form an intracellular vesicle or the phagosome. So the phagosome fuses with the lysosomal granule, and then during the process, the phagocyte also release lysosome contents in the extracellular space. So the process of phagocytosis is complex and involves the integration of many receptor-initiated signals, leading to membrane remodeling and then cytoskeletal changes. So the last is the intracellular destruction of the microbes and debris. So killing of the microbes is accomplished by the reactive oxygen species or the ROS, also known as the reactive oxygen intermediate and reactive nitrogen species, mainly derived from the nitric oxides. And these, as well as the lysosomal enzymes, they destroy the phagocytosed materials. So this is the initial step in the elimination of the infectious agents and the necrotic cells. So this is the picture of phagocytosis and intracellular destruction of the microbes. So this is the microbes which attach to the receptors of the cell, and then gini-engulf ang cell. So this is the process of engulfment, and then adto na hiya nagiging phagosome hiya, tapos ini nga phagosome i-introduce nga tuhan lysosome, and then the next step is the degradation na of the microbes or the killing of the microbes. So in the leukocytes, they are the most important cause of injury to normal cells and tissues under several circumstances. So as part of the normal defense against infectious microbes, when adjacent tissues also suffer collateral damage. So in some infections that are difficult to eradicate, such as TB and other viral diseases, the prolonged host response, they contribute to a more pathology than does the microbe itself. So when the inflammatory response is inappropriately directed against the host tissues, like in autoimmune diseases, the host reacts excessively against the usually harmless na environment, as in the allergic diseases, including the asthma. So in this situation, the mechanism by which the leukocyte damage the normal tissues are the same as the mechanisms involved in the antimicrobial defense. So the ROS, the nitric oxide, and the lysosomal enzymes, they are also released into the extracellular space, and they are capable of damaging the host cells such as the vascular endothelium, and may amplify the effects of the initial injurious agents. So termination of acute inflammatory response, the inflammation, they decline after the offending agents are removed, and then the neutrophils, because the neutrophils they are also short-lived and they have short half-lives in the tissues, and they die by apoptosis within several hours after leaving the blood. So as inflammation develops, the process itself may trigger a variety of stop signals that actively terminate the reaction. And this active termination mechanism, they include a switch in the type of the arachidonic acid metabolite produced, and the liberation of the anti-inflammatory cytokines, including the transforming growth factor B and the interleukin 10 from macrophages and other cells. So this table shows the inflammatory mediators, principal mediators of inflammation. So the most important is the histamine, and then we have the prostaglandins, the leukotrienes, the cytokines, the chemokines, and then the complement and the kinins. So for the vasoactive amines, the two major vasoactive amines include histamine and serotonin. So they are stored as preformed molecules in cells. And then the histamine, this is stored in the mast cells granules and is released by mast cell degranulation in response to a variety of stimuli, including physical injury, such as the trauma, cold, heat, binding of antigen to IgE antibodies on the surface of the mast cells, and this mediate the hypersensitivity reactions. And then production of the complement called the anaphylatoxins, or the C3A and C5A complex. And then serotonin, or the 5-hydroxyglutamic. This is also a preformed vasoactive mediator present in platelets and certain neuroendocrine cells, and primary function as a neurotransmitter in the GIP and the central nervous system. It is also a vasoconstrictor, but the importance of this action in inflammation is unclear. And then we have the arachidonic acid metabolites. So the lipid mediators are the prostaglandins and the leukotrienes, and they are present in the membrane phospholipids and stimulate the vascular and cellular reactions in acute inflammation. So the prostaglandins, they are produced by the mast cells, the macrophage, and the endothelial cells, and they are generated by the actions of the two cyclooxygenases, the COX-1 and the COX-2. So COX-1, this is expressed in most tissues, and COX-2 expression is mainly confined to the cells that are participating in the inflammatory reactions. So the leukotrienes, they are produced in the leukocytes and the mast cells by the action of the lipooxygenase, and are involved in the vascular and smooth muscle reactions and leukocyte recruitment. So there are three different lipooxygenases, and the 5-lipooxygenase is the predominant one in neutrophils. So the leukotriene D4, this is a potent chemotactic agent and activator of neutrophils, causing the aggregation and adhesion of the cells to granular endothelium and generation of the ROS and the release of lysosomal enzymes. So the leukotrienes, they are more potent than the histamine in increasing the vascular permeability and can cause the bronchospasm, usually involved in asthma. So the lipoxins, they suppress the inflammation by inhibiting the neutrophil chemotaxis and then adhesion to endothelium. So this is a picture of the arachidonic acids. So the importance of the eicosanoids in inflammation, they have driven the attempt to develop the drugs to inhibit the production or the action of and suppress the inflammation, like the cyclooxygenase inhibitors like this one, the COX-1 and the COX-2. They inhibit the production of the prostaglandins. So yun ay inhibit nila ang cyclooxygenase, inhibiting the production of the prostaglandins and the prostacyclin. So the cyclooxygenase inhibitors, this include the aspirin and the NSAIDs and the ibuprofen. So they inactivate both the COX-1 and the COX-2 and inhibit the prostaglandin synthesis. Hence, they are effective in treating the pain and fever. So the lipooxygenase naman, inhibitors, they inhibit the leukotriene production, the leukotriene B4, which is the responsible for production in, which is increased in production in asthma cases, and corticosteroids, they are broad-spectrum anti-inflammatory agent. They reduce the transcription of the genes coding many proteins involved in inflammation. And then the leukotriene receptor antagonists, they block the leukotriene receptor and prevent the action of the leukotrienes, and these drugs are useful also in the treatment of asthma, like the Montelukast. So for the cytokines and the chemokines, we have the tumor necrosis factor and the interleukin-1. So these two, the cytokines and the interleukin-1, they serve a critical role in the leukocyte recruitment by promoting the adhesion of leukocytes to endothelium and then migration through the blood vessels. So the cytokines, they are produced mainly by the activated macrophage and the dendritic cells. The TNF also is produced by the T lymphocytes and the plasma cells, while the interleukin-1 is produced by some epithelial cells. So the secretion of TNF and interleukin-1, these are stimulated by the presence of microbial products, a presence of dead cells and the immune complexes, also presence of varying bodies, physical injury. So the production of the TNF is induced by the signals through the toll-like receptors and other microbial sensors, and the synthesis of interleukin-1 is stimulated by the stim signal, but the generation of the active form is dependent on the inflammasome. So the most important role of the cytokines and the cytokines are endothelial activation of leukocytes and other cells, and then systemic acute phase response. So these are associated with infection or injury. So the TNF, they regulate the energy balance by promoting the lipid mobilization and then suppressing the appetite. So the chemokines, they are chemoattractants specific for types of leukocytes. So they are classified into 4 major groups according to the arrangement of the cysteine residues in the proteins. So they mediate their activities by binding to the 7 transmembrane G protein coupled receptors. So they have 2 main functions. In acute inflammation, they stimulate leukocyte attachment to the endothelium, and then they also stimulate chemotaxis and then maintenance of the tissue architecture para an offending agent or offending reaction diri hiya magawas ngadtuhan surrounding tissues. So the complement system, this is a collection of the plasma proteins and they function mainly in host defense against microbes and in pathologic inflammatory reactions. So the complement proteins, they function in both the innate and the adaptive immunity for defense against microbial pathogens. And in the process, the complement activation, several cleavage products of complement proteins are elaborated, causing increased vascular permeability, chemotaxis, and then opsonization. So the complement system, so this is a picture of the activation and function of the complement. And then the critical step in the activation is the proteolysis of the third component, so the C3, which is the C3. So the cleavage of the C3, they can.
Excuse me po, Doc.
Yes, yes. Hello. Hello. Yes, yes, Doc.
Medyo choppy ka po ata, Doc.
Sorry. Ito, clear na?
Yes po ata, Doc. Opo.
Sorry, mahina yung internet. So this is a picture of the activation and the function of the complement. So the important step here is the proteolysis of the third component, which is the C3. So the cleavage of the C3, they occur by one of the three pathways, which is the alternative pathway or the classical and the lectin pathway. The classical pathway, this is triggered by binding of the C1 to an antibody, usually IgM or IgG. And the alternative pathway, this is triggered by the microbial surface molecules. Examples are the endotoxins or the lipopolysaccharides, the complex polysaccharides, and other substances in the absence of antibody. And then the lectin pathway, this is the plasma minus binding lectin. They bind to the carbohydrates on the microbes and directly activates the C1. So all these pathway, they lead to the formation of an active enzyme called the C3 convertase, which splits the C3 into C3A and then C3B. So the C3A is released and then the C3B, it becomes covalently attached to the cell molecule, and then more C3B binds to previously generated fragments, and then they form the C5A convertase, which leaves C5 to release the C5A and leave C5B attached to the cell surface. So the morphologic hallmarks of acute inflammatory reactions are the dilatation of small blood vessels and the accumulation of leukocytes and fluid in the extracellular tissues. So, however, there are morphologic patterns that often superimpose these general features, depending on the severity of the reaction, its specific cause, and the particular tissue and the site involved. So the importance of recognizing the gross and the microscopic pattern is that they provide a valuable clues about the underlying cause. For example, in serous inflammation, this is marked by exudation of sulfur fluid into the spaces. Anadronsal nga fluid, actually transudate. So the fluid, transudate. So the fluid, it does not contain the microbes or the large numbers of leukocytes. So in body cavities, the fluid may be derived from the plasma or from the secretions of the mesothelial cells. Accumulation of fluid in these cavities and is called infusion. So an example of serous inflammation is the presence of skin blister. So usually in the skin blister under the microscope, when you cut the skin surface, may blister nga portion, makikita nimo nga na-separate ang iya epithelium na diha iya underlying tissues. Tapos in between may dahiya ini nga clear nga area, kuan ini diya may fluid. So ang tubig amo na ini yung tsura microscopic examination. So this is a skin blister nga microscopic picture. So in purulent or suppurative inflammation and abscess, this is characterized by the production of pus, and a good example of this is the staphylococci infection and in appendicitis. So in abscess, this is a localized collection of pus caused by suppuration in tissues and organ or in a confined space. So they have a central liquefied region composed of necrotic leukocytes and then tissue cells. So grossly, this is the appearance of abscess. And then microscopically, itsura usually neutrophils picture. Numerous nga neutrophils naka-confined hiyahin usang space. So for ulcers, these are a local defect or excavation on the surface of an organ or tissue produced by the sloughing or shedding of the inflamed necrotic tissues. So this is common in the mucosa of the mouth, in the stomach, as in gastric ulcers, in intestines, and the genitourinary tract. So the skin and subcutaneous tissues of the lower extremities, in individuals with disorders, they predispose to the vascular insufficiency, such as the diabetes, in sickle cell anemia, and the peripheral vascular disease. So a good example of ulcer is the peptic ulcer disease of the stomach or the duodenum, in which the acute and chronic inflammation, they coexist. So during the acute stage, may dahiya intense na polymorphonuclear infiltration, meaning damo niya neutrophils at the early stage of infection, and then magkakaadahiya vascular dilatation, hemorrhage defect, up with chronicity. This might from the base of the ulcer na develop in fibroblastic proliferation and then results to scarring, as well as the occupation of the lymphocytes, the macrophages, and the plasma cells. That's why usually in peptic ulcer disease, diarrhea, acute or chronic, usually nag-overlap and acute and chronic inflammation. So this is a microscopic, low power cross-section of the duodenal ulcer crater with acute inflammation, inflammatory oxidate on the base. On higher magnification siguro, nakikita gyapon nimo nga may adididi maligid may the inflammatory infiltrates. So mapapansin niyo aniya epithelium diri na hiya continuous kay na break hiyahan ulcer. May excavation na hiya dito area. The next is fibrinous inflammation. This develops when the vascular leaks are larger or there is a local procoagulant stimulus, usually caused by cancer cells, and the fibrinous exudate is a characteristic of inflammation in the lining of body cavities such as the meninges and the pericardium and the pleura. So histologically, the fibrin, they appear as a eosinophilic meshwork of threads or sometimes as an amorphous coagulum. So these fibrinous exudate, they may be dissolved by fibrinolysis and cleared by the macrophages. If they are not removed over time, they may stimulate the growth of fibroblasts and the blood vessels, leading to formation of scars and scarring. So the outcome of acute inflammation, uh, although as might be expected, many variables modify the basic process of inflammation, including the nature and the intensity of the injury and the site and the tissues affected and responsive, responsiveness of the host. So the acute inflammatory reaction, they typically have one of the three outcomes. Uh, One is complete resolution, wherein the removal of the cellular debris and the microbe by the macrophages and resorption of edema fluid by the lymphatics. They are followed by regeneration of the damaged tissues. And then healing, second is healing by connective tissue replacement or the production of scarring and fibrosis. So these tissues usually are incapable of regeneration, and then there is abundant fibrin exudation in the tissues or in serous cavities like the pleura or the peritoneum that cannot be adequately cleared na. And then the organization, the connective tissues grows into the results to organization, and then wherein the connective tissue, they grow into the damaged area, forming a mass of fibrous tissue. Or the last outcome is the progression of the acute inflammation to chronic inflammation. So this these pictures shows the summary of acute inflammation. So when a host encounters an injurious agent like toxins, trauma, presence of trauma or bacterial infections, the resident phagocytes and the phagocytes recruited from the blood, they try to eliminate these agents. So these are the phagocytes. They eliminate these agents, and then at the same time, the phagocytes and other host cells, they react to the presence of the foreign or abnormal substance by liberating the cytokines, the lipid messengers, and other mediators of inflammation. So some of these mediators, they act on the small blood vessels in the vicinity, and they promote the efflux of the plasma proteins and the recruitment of circulating leukocytes to the site where the offending agent is located. So the recruited leukocytes, they are activated by the molecules derived from the microbes and the injured cells and locally produce infiltrators. And this activated leukocytes, they try to remove the offending agent by phagocytosis. And then as the injurious agent is eliminated and the anti-inflammatory mechanism become active, the process na subside siya and the host return to a normal state of health. And if the injurious agent cannot be quickly eliminated, they may result to chronic inflammation. So the vascular and the cellular reaction, they account for the cardinal signs of inflammation, which includes the rubor, color, tumor, dolor, and tonsillitis. So the increase in blood flow into the injured area and the increase in vascular permeability, they lead to the accumulation of extravascular fluid, rich in plasma proteins, uh, and they cause edema. So the redness or the rubor, the color, and the tumor, these are caused by the increased blood flow and edema. While the circulating leukocytes, they initially they are predominated by the neutrophils. They adhere to the endothelium via adhesion molecules, and then later they transverse the endothelium na gawasira and migrate to the injury under the influence of the chemotaxis agent. So the leukocytes are activated. They may release the toxic metabolites and proteases extracellularly, and they can cause tissue damage. So due to the damage and the liberation liberation of the prostaglandins, the cytokines, these are one of the local symptoms of pain. So, and pain is secondary to the liberation of the prostaglandins, the cytokines na mediators. So, the loss of function or the function lysa, they result from the pain and the injury to the tissues and result to fibrosis na. So, this is it for the acute inflammation. So tomorrow, I will be discussing the chronic inflammation and the tissue repair.
Thank you po, Doc.
Okay. And PowerPoint, gahatag ko na lang after hand, mahumanan ang topic na tanan na.
Okay po, Doc. Thank you po. Tomorrow po, Doc, 9:30 po ba yun tayo? The same sa schedule po?
Oo. Scheduled kita tomorrow, 9, ano ka mga oras? 9:30 to 10, 11:30? 11.
9:30 to 11 po ata, Doc.
9:30. Maaraw na lang ako kan Zoom. Tapos, today, mapa-attendance na lang ako kan Doc Choan.
Okay po, Doc. I-forward ko na lang po an attendance.
Okay, sige. Thank you for listening.
Thank you, Doc.
Thank you po, Doc.
Thank you, Doc.
Bye-bye.
Thank you, Doc.
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 Hello? Hello?